Howdy. I'm here, Keelan Swain and Shannon Decker.
Hi.
VBC1.
Yes.
I'm saying VBC1, but those acronyms are what I want to talk to you about today.
Okay.
So the V stands for value.
Yep.
The B stands for the baddest. And C stands for value-based care.
Yep.
Right?
Yes.
And hopefully we want this to reach my startups in healthcare, my leaders in healthcare, my directors of community-led organizations. And currently we're in New Orleans talking about how can we actually integrate a lot of services in healthcare that may be non-medical, social services into value-based care. And one of the things I thought was very interesting, Shannon, I think you have a ton to talk about, is, what is value-based care? And, specifically, there's a ton of things that are motivating value-based care to really take over in the marketplace, right? So we'll start there.
So I think for a long time, people recognize that folks cannot get the care that they need at the right cost. That medicine is it's a fractured system. And so the whole intent of value-based care is to make sure that there's something that we refer to as the quintuple aim. And so it's the right care at the right time, at the right place, and then making sure that everyone has equal access to that health care.
That sounds like a hit song.
I know, right?
Yeah.
And then so that we're also protecting our clinicians who are getting burnout, I think.
Okay.
Americans are living longer, but they're not necessarily living healthier.
So burnout is the fourth.
It's the fourth, and then equity was added as the fifth. Yeah.
Quintuple. Oh, that's five.
Quintuple. Yeah,
Quintuple.
absolutely.
I was holding you back at quadruple, but they just quintuple.
They moved on.
Who is they? Like, who's this they that you speak of that changes?
Yeah.
That's changing like the way we're doing business and medicine.
So the quintuple aim actually, I think I forget the gentleman who it was attributed to, but I want to say that there was an article written. I want to say it was 2019. I have it, so I can share it with you. As far as who's changing healthcare, I think it's been going on for a while. I think when the government even introduced Medicare Advantage, and I want to say that was circa 2006 or so, 2008, when the risk model and things like that. But essentially, and value-based care isn't just limited to Medicare Advantage or Medicare. I mean, it's all age brackets. But I would think that's really kind of where it started, because the government felt that there might be other organizations, so privatized, right? Just like you have other industries. But the government felt that there might be health plans could potentially do it better, but they had to put in controls to ensure
the
that.
Government, right?
Yes,
okay.
yes. Sorry about that.
No.
Answer.
Thank you. No. Keep going. Keep going.
Yeah.
I just wanted to highlight that for the people.
But I think. They thought, the government thought that they could potentially privatize it and it could be handled better, and that it would give people options and you would have that competitive advantage. So it would force people to be innovative. And then, they also included things like, what they found was that a lot of times the health plans were a little hesitant or resistant to taking on patients that were sicker. And so then there were a lot of things that were put in place, like you have the risk model with Medicare Advantage. So physicians were paid for taking care of patients where they were going to spend more time. But there were also things like you couldn't preclude someone for pre-existing conditions.
Oh, wow.
There were other greater permissions that were added with children, with maternal health, and so those types of things.
Now that you went through some major parts on the government, and why that's important on the actual startup or administrator or community-based organization side, is that this is forcing the insurance plans or payer like a Blue or United to create more ways that someone can get paid outside of a fee schedule. So fee schedule, for those who may not know, are CPT codes that normally a physician or nurse practitioner or registered dietitian can get reimbursed from by the government. However, these things can be limited because there's only a certain amount of services, and as well as they may not necessarily be outcome based, right? Some of them. And so what that ends up creating are systems where I've seen it. You go to the hospital and they got to get you in within 15 minutes because the business is all about volume. But switching to value, you have those quadruple, quintuple, all those oople lanes.
Yes.
Right? It's going to be 6 aims in the future. But the value makes it so like we want things outcome to reduce the cost, but increase the outcomes. And so that kind of, is pushing on the old school business model of healthcare. And, I think that's an interesting point.
So if you think about it, to your point, doctors were paid for the visits that they had.
Yeah.
And so it was very transactional. I think that there's a paradigm shift. So it goes from being reactive, where you come in and you're sick and they diagnose you and they give you a pill and you go away. And I'm not meaning to simplify it, but just for illustrative points. But now things are becoming more prescriptive. And so if I can keep you healthier at the beginning, because that's the thing, medicine has gotten good in that if you get really sick, they can preserve your life. That's taxing on the system. It takes up valuable resources. But if they can do things like get you to get your preventative screenings, improve outcomes, the better. Not only is it less expensive, it's less of a taxation on the system. Doctors can be used for patients that actually need the services, and I think it also then puts onus on us as American people to be healthier.
So how fast is this value-based care growing, right? Who's adopted it? What type of organizations are actually using it and making it viable? Is it 100% of organizations, or is it 30%?
Not 100% yet, but they'll be there. So the mandated, well, not mandate, but the mission is that everyone will be in every person will be in a value-based care contract.
Every person?
By 2030.
Oh, wow.
By 2030. There's lots of different programs.
That's 6 years.
I know. CMS is, and others, right, within the government. So it's other organizations, too, I think are pretty ambitious. HHS and others, but that's the plan. And so we see more and more different types of contracts and ability or ways to share risk. It's not just, I know I mentioned Medicare Advantage earlier, but there's lots of other programs where people can take risk on all different types of populations, be it maternal health. You even see programs that are developing now in oncology, in kidney care. So I think that we're going to continue to see more of one.
Now, the thing that I really like about this conference is that we're in New Orleans and it's titled SDOH Conference. And so one thing they're trying to push here is, I'm in the diabetes space, but a lot of things we focus on are more social to solve for diabetes. And a huge part on the reason, I think the stat says a lot of the medical issues we face are non-medical, based on community or systematic or education. Those determinants, it's like 80% of medical outcomes are based on like what zip code you're in, what's your financial status, how great is your access to healthcare, how great is your access to food. And so I think there's a huge opportunity for community-based organizations to get involved in this angle as well, not just the physicians or the hospital associations. Can you talk more about that?
Yeah, absolutely. I think the statistic, the one that I heard, but again, it's recalling from memory, is 30% of our medical outcomes are driven by our actual health and genetics. The rest were, predisposed by our environment. And then, but would absolutely agree with you. And actually, the biggest predictor of health outcomes is education. And so health literacy, I think, figures largely into that. There are a lot of programs across the country now where health plans or medical groups are partnering with CBOs and providing them a share of the risk. And so for those that don't know, you're typically reimbursed for the patients that you have, and we know the burden of illness that a particular patient carries, either because of, like you said, where their zip code is, their gender, their age, but then also to the conditions that they may have that they've been diagnosed with. And then if you have the opportunity, right, so they're reimbursed for that. So there's a certain monetary value that's ascribed to that. And so if you're able to maintain that patient, there's an opportunity to share in those monies. So if you think of it like this, everyone might be assigned a risk score. Different programs are different populations are ascribed different values and reimbursed in different ways. So there's other models that are out there. But you're reimbursed for a certain amount. Your care, right, is going to cost a certain amount. I like to think of it as, and I'm probably misusing the business term, but like this arbitrage opportunity, so that if you can slow down the progression of the typical disease course that we know is going to be associated, say, with COPD or diabetes, but you're reimbursed at that value, right? There's more money that's available then that you can put into those plans, so that hopefully that person never gets to those more extreme cases, right? That person never gets to CKD stage 4 or 5, right? They never get to end stage renal disease, that you're able to maintain them at a much healthier level. And then obviously, right, it's lesser cost. And again, that goes back to that paradigm shift in what I was talking about before, is that prior to these types of models, people would get sick and then they would end up, right, exacerbated and at those other ends of the spectrum that were much more costly. And so again, if there's things that we can do to prevent those types of things from happening, it not only benefits patients, right, for having better outcomes and their families and so on and so forth, but it also improves the cost that's associated with caring for those diseases. So there's lots of different contracts that you can enter into. There's shared risk, where you're only taking partial risk. There's something called, and a lot of times too, so it can be shared risk, it can be global risk, where you're taking risk on everything. Some people refer to some portions as professional risk, and that would be primary care visits. So there's all different types of contracts, depending on the population too that you're involved in. So a lot of times people will do shared risk on commercial, but they'll take global risk on Medicare. There's lots of different programs. There's the AHEAD program, which allows hospitals to participate in risk sharing.
Oh, wow.
We have ACO REACH, we have PCP Flex, we have Medicare Advantage, which allows primary care physicians to participate, as well as health plans.
There's 6 different models.
There's
Is this the
tons.
difficulty of value-based care, the different
I
financial models?
Yes and no. I think that one of the things that the government is trying to do is try a lot of different things.
Yeah.
And they learn and then they implement best practices and then start other types of programs that they think are better, so that they can get to that better outcome. So I like to think of it like a petri dish, and there's several of them, and they're trying, different things. As far as, getting involved in those contracts, I don't think it's difficult, but here's what I would say, is I've seen a lot of people get really excited because there is potential, right, to do well for yourself and actually be reimbursed for the work that you're doing. But the challenge is you have to have an honest assessment of what your systems are and whether or not you're ready for that.
Yeah.
And I think ACO REACH was a perfect example of that. We saw the program almost increase 5
What's ACO
times.
REACH again?
It's where they're ACOs, so they're Medicare patients, Medicare fee-for-service.
Yeah.
They're where physician groups can partner with CMS and actually engage in these risk-bearing contracts. They have the opportunity to choose between professional risk and global risk. It was a great learning because unlike Medicare Advantage, it's on a different time schedule as far as some risk scoring and payments.
What do you mean time? Like every 12 months?
Like how they're
they can
calculating
bill
the score.
CMS and get paid.
How they're calculating the score for those patients.
How they calculate the
often it's updating. Medicare Advantage allows for a little longer of a runway. And then also too, the reimbursement is different. It's on a population level as opposed to individual. There's a lot of nuance to a lot of this stuff. But I think that ACO REACH allows physicians to participate. Not that they haven't been backed by some other larger partners. But what I would say is do an honest assessment of where you're at. And so when a lot of those groups signed on for ACO Reach, they signed on for global risk, and what they didn't realize is that global risk includes all risks associated with a patient. So if you haven't implemented programs where you are encouraging patients, say, to go to urgent care because it's a more appropriate side of care for whatever it is that they're being seen for, or you're not educating them, say, to take care of their diabetes to the extent that they can and be compliant with their insulin schedules or medication schedules and things like that. If you're not doing those things, they can have exacerbations that would cause them to end up in the hospital, possibly be admitted.
And that ACO Reach is that they're taking on all costs
Exactly.
of this patient.
So that's global risk.
They may get global risk is from CMS. They'll get 1,000 patients, or 10, let's say 1,000 patients in this zip code,
Right.
or this city, or this county.
It's
Right.
usually determined by claim. So if your doctor is participating and you go to them as a patient, you'll be assigned through that ACO.
And so they're responsible for all your costs
Yes.
associated to healthcare. So if you get an amputated leg because you're diabetic, then that will be the responsibility of ACO Reach. And that may be a loss on their level because of
Yes.
poor management potentially.
So if you're a physician group that
Yeah.
has an ACO Reach contract and you have that where a patient gets to that level and it's not managed, then yes, if you signed up to take global risk, then you would be, unless there's like a particular carve out, which some contracts allow for that, but you would be responsible for that. And
So global risk is 100%. Is there something in the middle of global risk, like shared risk?
No, so with ACO Reach, no, it's professional or it's global. So it's either or. Professional risk would just be for ambulatory settings. So that would be your like primary care visits, specialist visits, those types of things. It wouldn't include hospital, whereas global risk would. And so really knowing your patients and whether or not you have the ability to shape their behavior of how they're taking their
Wow.
product.
So did that experiment work with the government? ACO Reach, did that, are they still
I think,
promoting
yes.
it? Is that growing?
It is. So the first year for it, off of memory, 23. The first applications were put out in 22. It was actually another program prior
You
to
said
that.
2023?
2023.
This
So
is
the
that's
second
last
year.
we're in 24. That's
Yeah.
last year. Oh,
Yeah.
wow.
There were a lot of learnings along the way. CMS did issue some changes. So they did provide some, what do we say, some easements, if you will. So because a lot of provider groups took on global risk and they just weren't ready for it. There were very few that took on professional. I think there were maybe like 5 or 6 out of the entire list.
Didn't
and there were
realize
like
it.
over 100.
So that's one of the pros. So one big part about value-based care is that you can make more money,
You can make more money if
but
you
the
do a
risk,
good job.
if you do a good job.
Yeah.
But the risk involved is the thing that it sounds like a lot lessons learned for those physician groups. But it sounds like should startups be talking to ACOs or community-based organizations be targeting ACO Reach groups as a partner, or
Yeah, I think so. Because again, to what you were saying, if you're going to continue to practice like you did in a fee-for-service environment, you're not going to do well in those types of programs. So when we say paradigm shift, it's a full shift, right? Everything needs to change. And so you can't be reactive, you have to be proactive. And I think that you have a lot of startups out there and innovative thinkers like yourself that if you can provide programs that again can shape behavior and change what we know to be the typical trajectory, right? And that was not well managed care. So that if you can educate and provide guidance and do all of these other things that are necessary that we know are successful in shaping behavior, you could potentially change not only, again, the patient's outcomes and their quality of life, but also to the expense that it would take to take care of them should they be exacerbated or follow that typical trajectory.
no? That makes a ton of sense. That makes a ton of sense because it seems like value-based is more aligned with preventative care.
Yeah.
But the issue with value-based is who's doing it and quickly figuring out who's doing it, and aligning yourself to that cause. And so, but no, this was a great beginner lessons learned. So like the startups out there, the pitch, the CBOs, the leaders, aligning with that preventative mindset and understanding what quintuple aims you're a part of, and also knowing what measures or quality improvement measures that they're having to push.
Right.
Seems to be some huge opportunities.
Absolutely. I mean, we know a lot of things, right, about disease progression. We know that, like, for instance, with diabetes, that most diabetics, that a lot of times the diagnosis comes through an eye exam because one of the first impacts, at least through years 1 through 3, a diabetic is going to have some impact to their eyesight. And so we want them to modify, right, their diet, get healthier, exercise, control their blood sugar, because one of the first places where diabetes shows up is affecting the system is in the eye. And so one of the quality measures, right, is diabetic retinopathy. They should be screened every year. If they're not doing things to control that and getting that testing, we know that in about 10 years, they'll have significant eye damage and possible loss. And blindness, right, is much more costly. And then also, too, it's not a good outcome to have because who wants to lose their eyesight and all the impact, right, and all the other systems that something like that would do. So, you know, again, if you can do things to maintain their health, preserve their function, and those types of things, all the better.
Yeah. Any last words?
I think healthcare is going to be a really exciting environment to be a part of. And I think, though, know that it's very difficult. So it's not an easy way to get in. It's not all easy money. There's a lot of hard work that needs to go into, you know, what you're thinking of doing. And I think, you know, be humble, have humility, and listen. But again, I think that there's lots of opportunity.
So, there you have it, guys. Let's give them a wave goodbye. We're here in NOLA, and we're closing things out. Peace.